The new high-sensitivity troponin assay will be reported in nanograms per liter rather than nanograms per milliliter. The following table demonstrates how troponin values reported by the contemporary 4th-generation assay might compare to a value reported by the 5th-generation high-sensitivity assay. As you can see, for higher values, one can simply divide the reported value by 1,000 to convert from nanograms per liter to nanograms per milliliter. This rule breaks down at smaller troponin values due to imprecision in the older assay. Thus, a troponin value of 30 nanograms per liter by the new assay corresponds to a value of just 0.01 nanograms per milliliter by the old assay. Although no single troponin value can be used to confirm an acute myocardial infarction, the higher the value, the higher the positive predictive value for a coronary occlusion as the mechanism of injury. Any value above the 99th percentile is defined as a myocardial injury. In the inpatient setting, serial troponin values should not be trended more frequently than every 3 hours. This is in contrast to the emergency department, where algorithms employing more frequent troponin monitoring have been validated. The myocardial injury is considered chronic if there is no significant rise or fall in the troponin level at 3 or 6 hours. It is considered an acute myocardial injury if there is a significant rise and fall at the 3-hour or 6-hour time point. For higher initial troponin values, a 20% relative change from baseline has been proposed to define a significant change, or delta. Thus, if the initial troponin value is greater than 100 nanograms per liter, a delta of greater than 20% likely reflects an acute myocardial injury. If the initial troponin value is greater than 100 nanograms per liter and the delta is less than 20%, acute myocardial injury is less likely. If the initial troponin value is less than 100 nanograms per liter and the delta is greater than 20 nanograms per liter, acute myocardial injury is likely. If the initial troponin is less than 100 nanograms per liter and the 3-hour delta is less than 6 nanograms per liter, acute myocardial injury is unlikely. If the initial troponin is less than 100 nanograms per liter and the 3-hour delta is between 6 and 19 nanograms per liter, a repeat troponin level at 6 hours is recommended. If the myocardial injury is acute, we next consider symptoms, ECG findings, and cardiac imaging patterns to determine whether the injury is ischemic or non-ischemic in nature. Chest pain that is substernal, provoked by exertion or emotional stress, and is relieved by rest or nitroglycerin is more likely to be ischemic. ECG findings of ischemia are beyond the scope of this brief tutorial. However, additional resources can be found at bit.ly/hstropes. If the etiology of acute myocardial injury is deemed ischemic, the mechanism should be further characterized as type 2 versus type 1, depending on whether the ischemia is thought to be secondary to coronary occlusion from erosion, plaque rupture, or thrombus. Non-ischemic mechanisms of injury may be either chronic or acute and include chronic kidney diseases, pulmonary emboli, or stress cardiomyopathy. Type 2 myocardial infarctions are due to either supply-demand mismatch and may be due either to systemic processes such as sepsis, anemia, or hypoxic respiratory failure, or cardiac causes such as tachyarrhythmias, coronary vasospasm, or SCAD. Type 1 mechanisms include NSTEMI and STEMI and are due to either acute coronary plaque rupture, erosion, or coronary thrombus. Type 1 mechanisms of myocardial injury, such as NSTEMI and STEMI, should be treated per myocardial infarction guidelines with interventional procedures and/or medical therapy. The management of non-ischemic myocardial injury and type 2 myocardial infarction relies on the identification and treatment of the underlying insult. Non-ischemic myocardial injuries should be documented as such and include the presumed underlying cause, such as ESRD. Type 2 myocardial infarctions also should include the presumed underlying mechanisms of supply-demand mismatch, such as septic shock. Documentation of STEMI should include the vessel or myocardial segment involved. The term NSTEMI should only be used when documenting a type 1 mechanism. Type 2 NSTEMI is an incorrect term and should not be used. Using terminology that implies myocardial ischemia or infarction when clear evidence of myocardial ischemia is lacking can unnecessarily affect quality metrics. Patients with documented type 2 MI, NSTEMI, and STEMI are included in the Hospital Readmission Reduction Program, or HRRP, for which hospitals are subjected to financial penalties if the 30-day readmission rates exceed risk-standardized readmission rates. For this reason, in the absence of clear evidence of myocardial ischemia, myocardial injury should be documented as non-ischemic myocardial injury. For more information and quick answers to frequently asked questions, visit bit.ly/hsstrokes.